Good afternoon. Welcome to AETCM, Emergency Medicine Channel. So today I'll be presenting a case of a 41-year-old male who presented to ER with complaints of abdominal pain. Shall I start?
Please.
So the patient is a 41-year-old male who's working in a hotel at Kakinad. Hometown is from Bihar, but staying in Kakinad for the past 15 years. Comorbidities, he has no comorbs as such. He came with complaints of abdominal pain for the past 15 days. History of presenting illness. So patient was apparently normal 15 days back when he had complaints of abdominal pain for 15 days, which was right-sided, involved the right hypochondrium to iliac regions, and it was insidious in onset, gradually progressive. It was radiating to the back and with no exaggerating factors, but relieved on taking analgesics. He also gives a history of fever for 15 days on and off. Mostly evening rise of temperature, which is high grade, associated with chills and rigor, and it is relieved by taking antipyretics. And then he also gives a history of cough for 15 days, which was occasional, associated with a scanty sputum, which was white in color, mucoid in consistency, not associated with any hemoptysis. He also gives a history of breathlessness for past 15 days. It is more on climbing stairs and is relieved on taking rest. It was gradually progressive, but no history of any orthopnea or PND. And he also gives a history of loss of appetite. Otherwise, there was no history of any sore throat or dysphagia or vomiting or loose stools or burning micturition, headache, loss of consciousness, seizures, or any loss of weight. So past history was not significant except for the fact that over 10 years back he had a history of jaundice and was admitted in a hospital for 4 to 5 days, which was treated conservatively. Personal history: he is an alcoholic since 20 years of age, drinks occasionally 6 months once. Last drink was 6 months back. Not a smoker. He eats both vegetarian and non-vegetarian diet. Has a travel history to Bihar in the month of August, after which he has not travelled anywhere. No contact to any pets or any farm animals or any mud exposure or anything. Drug history: takes analgesics and antipyretics in case of abdominal pain or fever. Coming to the examination.
Can you just summarize the positive findings for
Yes,
41-year-old presenting with acute abdominal pain for like 15 days? And
associated with fever, cough, and breathlessness. Yes, sir. With loss of appetite.
What do you suspect? When you are seeing a case like that, we have to proceed, no? So we will have some differential diagnosis in our mind.
So a patient gives a vague history of abdominal pain. So probably a gastroenteritis which was not treated properly with
15 days.
15 days.
But he is not having diarrhea, no? Diarrhea is not there, vomiting is not there.
Or a subacute pancreatitis or something.
Where is the pain?
A right-sided abdominal pain, sir, but radiating to the back.
Where is the pain in pancreatitis?
It'll start from the umbilical region.
Where it radiates?
To the back.
Back. What are the other? So it is unlikely, but it can be pancreatitis, a chronic calcified pancreatitis. They have repeated pain, but it is more like a spasmodic pain than a chronic type of pain. Okay. What other differential diagnosis you can put?
any connection with liver abscess?
Liver abscess. They will be toxic. Liver abscess is one condition where the patient will be highly toxic. TB abscess can be non-toxic, but all other liver abscess, common liver abscess, patient is highly toxic. Look, if you see in one patient, you will never forget it.
Any subacute cholecystitis?
Okay, cholecystitis. Where the pain will radiate?
Radiate to the
Right
shoulder.
It radiates. Radiation is mainly to the shoulder, but it can be cholecystitis. Can be. It's a female patient.
Male patient.
Male patient. Okay. In which category of patient cholecystitis is common? Cholecystitis or like stones in the gallbladder is common in female patient.
Taking OCPs.
Okay. Obese female patient. Okay. Chronic abdominal pain, what are the reasons?
Any gastritis.
Gastritis.
But it is right-sided, sir,
Okay.
for him. Then
Can this be a pyelonephritis, or you're talking about fever symptoms also, no?
Yeah.
Commonest cause of abdominal pain with fever is urinary tract infection, pyelonephritis, chronic pyelonephritis. One of the common presentation is that we are seeing many patients in even our ER. Many of the patients are having pyelonephritis, chronic cystitis, pyelonephritis. This is a common cause. That's all things what you told is correct only, but this has to be there in the differential diagnosis. Okay. Continue.
On examination, patient is conscious oriented. On general examination, there is no pallor, icterus, cyanosis, clubbing, or any generalized lymphadenopathy. There were no signs of chronic liver disease such as spider nevi, gynecomastia, or parotiditis. Vitals, BP was 160/100, which was measured in the right upper limb. Pulse is 89 per minute, regular, normal volume and character, and peripheral pulses were also felt. Respiratory rate is 20, and saturation is 97% in room air. But temperature was 100 Fahrenheit. He was febrile on examination. Coming to systemic examination, per abdomen on inspection, the abdomen was distended, but there were no dilated veins on inspection.
How do you examine for dilated veins? What should be the position of patient?
Standing position.
Without standing position, you cannot comment whether dilated veins are there or not. Okay. If you want to comment, you make the patient stand and see. Otherwise, you should tell that I have not examined.
Okay. On palpation, there was tenderness in the right hypochondrium and umbilical as well as right iliac regions. And
so suppose the patient says abdominal pain to a localized area, how will you start the palpation?
From the opposite side to last should be the site of pain. And then on percussion, there were flank dullness and shifting dullness was also present, but no fluid thrill. On auscultation, bowel sounds were heard, no bruit or anything was heard, and perineals and genitals on examination was normal. And RS exam.
When you are auscultating for bowel sounds, how long are you going to look for the bowel sounds?
1 minute.
Okay. Minimum at least 30 seconds.
No, 30 seconds. 1 minute. Okay, 30 seconds is enough.
Okay. Respiratory system examination, bilateral air entry was heard, normal vesicular breath sounds in all the areas except for right infraaxillary and infrascapular areas where the breath sounds were diminished.
Okay, so you have tried for a percussion?
Percussion, there was a dullness in the right infraaxillary and infrascapular areas.
Okay.
Other serious examination, S1, S2 heard, no murmurs. NS, high mental functions, motor and sensory, everything was normal.
So what will be your clinical diagnosis after completion of your examination?
So patient has come with complaints of abdominal pain, fever, cough, sir. But the system that I wanted to focus more is GIT, because on examination patient has abdominal distension with a shifting dullness. So my differential diagnosis would be patient presenting as an ascitis and probably related to CLD or something, sir, because it is most common, though the source is not identified.
Okay.
And patient.
But this patient doesn't have pedal edema, no?
No, sir.
So one of the common presentation of CLD with ascitis is they generally have pedal edema. Why should they have pedal edema? What are the mechanisms of fluid accumulation in a case who is having ascitis? Who is having liver disease and producing all these things?
There'll be third space fluid loss, and that can be secondary to hypoalbuminemia.
One is hypoalbuminemia. Then second one. There are multiple mechanisms. As a medicine PG, you have to tell it. One of the common thing is hypoalbuminemia. That is correct. Second one. Obstruction of flow of blood or lymph, whatever it is. That is second thing. Third one. Secondary hyperaldosteronism. So there are multiple mechanisms are there for this one, but somebody is having a peritoneal infection, that is only collection there.
Yes,
so somebody is having a problem in the abdomen, they have ascitis, there is no pedal edema, then probably liver disease is ruled
Ruled
out
out.
clinically, but we cannot tell it is. Sometimes patient may be taking Lasix or something, it can present like that. Since this patient is not taking any treatment, then there is a high chance of peritoneal infection. Okay, since he is not having any pedal edema. Okay.
So the patient has an ascites for which the etiology has to be ruled out.
Okay.
And other
So what are the etiologies of 41-year-old male who is only having ascites? What are the etiologies you will suspect?
only having is
He is having ascites. What are the etiologies?
One could be TB.
One is TB. In India, there is a commonest presentation. TB is one possibility. Then? Malignancy. Second thing is malignancy. Even his age is only 41, but malignancy can occur. So malignancy is one condition where you can get only ascites. There may not be pedal edema. Then?
Extrahepatic obstruction.
Venous thrombosis. Okay. Extrahepatic venous thrombosis also can acutely present with abdominal distension. Afterwards, they develop all the features because of the pressure the effect. They can have pedal edema. So these are the differential diagnosis we should think. Okay. And what you do now? This patient does this patient require any emergency care from your point of view?
From primary surgery, actually, it's airway breathing circulation, everything is
normal. Okay. So this patient does not have a major life-threatening problem. So we will not be interfering in a emergency point of view. We need to investigate this case first. How do you investigate?
Sir, initially all the blood routines.
What blood routine you have taken?
So first CBC was taken.
What happened to that?
Total counts were 6,000. Hemoglobin was 12.5 and platelet was 5 lakh.
5 lakh.
Neutrophils.
So platelet is high. What do you think that platelet is normal? Then it's a upper range. 4.5 is upper range. This is 5 lakh. What do you think?
Something can be considered down the line. Rule out a certain diagnosis. And
CLD can be ruled out.
One thing. And
CLD, actually it is wrong. CLD, it is 5 lakh, not low. It is very high. So
Yes, sir.
CLD,
So
what happens?
There is
It
thrombocytopenia.
goes down. Okay. This is very high. So what are the differential diagnoses you think? A very high platelet count indicates what? In a patient like this. What is that? It's a chronic inflammation. High platelet count just indicates a chronic inflammation. If you treat the chronic inflammation part, it will come down. Okay. It's a secondary thrombocytosis. Okay.
ESR was 47, sir.
Okay.
And CRP was 106 with a procal of 0.1.
Okay. CRP is very high. Procalcitonin is normal. So it is an inflammatory condition. Okay.
Yes, and then RFT, urea was 22, creatinine was 1.0, LFT, total bilirubin 0.4, direct bilirubin 0.1, total proteins were 6.7, out of which albumin was 3.6, globulin was 3.1, SGOT was 23 and SGPT was 17 with an ALP of 54.
Alkaline phosphate is 54. So liver is not at all involved. Okay.
GGT was checked and it was only 19.
Okay, that's also normal.
Yes, sir.
Okay.
And because patient had an abdominal pain, we had done an amylase and lipase, which was on higher normal range. Like amylase was 116.
Okay.
Lipase,
Is it abnormal or normal?
little high, sir. Normal,
When you call it as abnormal?
only when it's 3 times more
3
than
times.
the
Normally is around 100. No, our lab value is 100. So more than 300, we should be very careful. It's only very marginally elevated. It may be normal for that fellow.
Yeah. Lipase was 137.
Okay. Even then it is normal.
Electrolytes were on normal range. Like sodium was 138, potassium was 4.2, calcium was 8.5, and magnesium was 2.2. And thyroid functions were also checked, with TSH was 1.1 and T4 was 1.5. So pre-op serology was done to rule out immunodeficiency.
Okay,
That was all
HIV,
non-reactive.
okay.
So these are the basic investigations that were done. So next we urine routine was done, which was showing only 0 to 2%.
Normal.
Yes, sir. and then we proceeded on to USG abdomen, sir.
Okay.
USG abdomen was showing a altered liver ecotexture with no surface irregularity.
Okay. So will you believe that ultrasound finding with your clinic? See, ultrasound is done by a doctor.
Yes,
Okay. It can be right or wrong. Will you believe with your LFT findings are more?
normal.
It's normal.
Yes.
So altered ecotexture, even in a routine ultrasound, may not be very correct. Okay. Since we are not suspecting any chronic liver disease, LFT is absolutely normal. There is no AG reversal. So that should be taken as a like slightly wrong report. Okay. But if you want to know better, we have to go for a fibroscan.
Yes, sir.
Ultrasound fibroscan. Okay.
No splenomegaly, but mild to moderate ascitis was present with no hydroureteronephrosis, and mild right-sided pleural effusion was present.
Okay.
And then
Why all patients who is having ascitis develop pleural effusion on the right side?
transport of fluid from the peritoneum to pleura.
Why right side is
to the
preferred over
right
left side
side?
is the best?
Why right side is
More
more?
common.
All openings are on the right side.
Yes.
That's why. Okay, it's very simple. Every major vessels are going on the right side. So there is a high chance of infiltration of fluid to the opposite side. Any abdominal condition can have left-sided pleural effusion. Pancreatitis. Pancreatitis is present with left-sided pleural effusion. Any conditions can have left-sided pleural effusion other than pancreatitis. There are so many conditions can have bilateral pleural effusion. We are not discussing about that. Specific condition which produces left-sided pleural effusion. That only produces left-sided pleural effusion. Thoracic duct obstruction, okay, above C7 something, which produce only left-sided pleural effusion. Okay. So we have to be very careful when we are seeing left-sided pleural effusion. Right-sided pleural effusion is very, very common in emergency room. Like any patient who is coming with ascitis will have right-sided pleural effusion. Okay.
And then because USG was showing a mild to moderate ascites, tapping was done, and around some 3 liters of ascitic fluid was removed, and it were all sent for analysis.
Okay.
And the ascitic fluid total count was 5,800, out of which 80% were mononuclear cells and 20% were segmented cells.
Okay.
Glucose was 81. ADA was elevated, it was 86, and LDH was 346, and proteins were 5.01.
Okay.
So because ADA was elevated, suspecting a TB, ascitic fluid was also sent for a gene expert MTB, which was positive for Mycobacterium tuberculosis.
Okay. What was the pleural effusion finding?
Pleural effusion,
Was
because
not
it was only mild pleural effusion, tapping was not done.
Okay.
And clinically also patient did not have any breathlessness or tachypnea.
Okay. Then what we should do now?
Just
now
since
that
you told we have tapped more like 3 liters and all. So usually what extra caution you have to take when you are going for large volume taps? What can happen to the patient?
Large volume paracentesis.
Rebound
What
ascites
precautions you have to take?
Albumin infusion should be given.
When we are tapping higher amount, especially more than 5 liters, here you are only tapped for 3 liters. Even then we should be very careful. When you are tapping like that much amount, patient can go to the hypotension. Okay. To prevent that, we are giving albumin. But how albumin will prevent this hypotension?
Intravascular volume. It maintains intravascular volume, sir. So
if you give 100 ml of albumin, how much intravascular volume will increase? How much albumin?
5 times.
Albumin as such 100 ml will remain in the intravascular compartment, and it additional 30% it will draw from the extravascular compartment. So maximum it can increase only 130 ml only. Okay. So even when we are talking about paracentesis with albumin, the ideal dose should be somewhere around 500 ml, but the cost does not allow us to give that much amount. Even then a small amount will slightly increase the BP, so patient may not go suddenly to hypotensive state. Okay, we can just prevent it. Okay, but it's very costly.
You know, what are the two albumin preparations available usually?
20 and 100.
20 and?
20 and
5% and 20%. That's 5 grams and 20 grams.
So 20% comes in small bottle, 5% comes in large bottle. Okay.
And patient was ascitic fluid showed growth of Mycobacterium tuberculosis. So we concluded as a
What
patient
test you did for confirmation?
gene
GeneXpert.
expert MTB
What extra information you'll get from GeneXpert?
resistance, rifampicin resistance,
Okay.
and it was negative, so not
Okay.
detected. So patient was started on first line ATT, considering his weight was 70 kg.
Okay.
So we started on isoniazid 300 mg, rifampicin
Can you
600.
tell per kg body weight dose for INH, rifampicin, ethambutol, pyrazinamide?
Yes, sir. 5 mg per kg for
INH.
INH, and 10 mg per kg for
Rifampicin.
rifampicin.
Ethambutol?
15 mg per kg.
Pyrazinamide?
15 to 20 mg.
Okay.
So considering the way, INH 300 mg was started, rifampicin 600, pyrazinamide 1600, and ethambutol 1200,
Okay.
along with pyridoxine 40 mg was started.
What is the ideal dose of pyridoxine with ATT?
10 to...
It is 10 mg. 10 mg is enough, but available dose is only 40 mg. Okay.
So he was monitored for any transaminitis is there or not, but right now he's not having any transaminitis. Subabdominal pain has come down, and he did not develop any ascites after that, and he's clinically better. So CRP was 106 on admission. It slowly raised to 150, but now it is coming down again. So yes, sir.
What is the most important clinical finding tell you that patient is improving in TB?
Weight gain.
Pain will take some time. What is the most important? As a clinician, you should know patient is improving. Fever is not that good sign. Appetite is the most important sign. Okay. Once the patient tells that appetite is come back, that indicates that TB is coming down. Okay. How long you have to continue ATT?
Sir, for this patient, we should continue ATT for 6.
How do you continue?
Intensive phase and continuation.
Intensive phase is?
Intensive phase is for 2 months.
INH, rifampicin, ethambutol, pyrazinamide.
And a continuation phase is for 4 months with INH and rifampicin.
Okay. What are the common side effects of anti-TB drugs?
One is transaminitis, sir.
SGOT, SGPT can be elevated. Which one will be more specific for drug-induced hepatitis? SGOT or SGPT? SGPT is more specific for drug-induced hepatitis, whereas in alcohol-induced hepatitis, SGOT is elevated. Why SGOT is elevated there? Is it SGOT elevated or SGPT reduced? It is SGPT actually reduced. SGPT is not produced in alcohol-induced. Not in all patients. SGPT will not be produced properly. Okay. Whatever it is, SGOT, SGPT will be, we have to monitor it. Okay, when the patient on ATT, if the patient develops slightly elevating SGOT, SGPT, what do you do?
We give hepatoprotective drugs first.
What are the hepatoprotective drugs?
Ursodeoxycholic acid.
That will protect the liver.
And
none of the drugs can, what is given in standard treatment will protect the liver. Okay, there is no liver protective drug available at present. Okay, so we don't have any liver protective drugs, but we have to continue treatment.
Yes.
So how do you treat this patient? Suppose the SGOT, SGPT after 1 week it is 60 and 45 or 50. What do you do?
Frequent monitoring should be done. And should be patient should be told about the symptoms.
At what level you stop the drug? If the SGOT, SGPT further on next visit it is 80 and 70, what do you do? And will you stop the drug, and what intervention you can do if the liver enzymes are elevating? Symptoms with 3-fold elevation, stop the drug. Asymptomatic, 5-fold elevation, stop the drug. How do you stop and restart the drug if there is a liver enzyme? This is a common problem, that's why we are discussing. If SGOT, SGPT elevates in a patient who after starting ATT, when will you restart? How do you restart?
What drug will you stop?
What all drugs you stop?
Rifampicin, first pyrazinamide, then Pyrazinamide can be stopped in case of thing and then monitored. And rifampicin can also be
So all pyrazinamide, rifampicin,
ethambutol.
INH, all are liver toxic drugs. Okay. So when the patient develops SGOT, SGPT elevation, we will not be knowing what drug is producing this problem. So better to stop all these 3 drugs, continue ethambutol. Some books says stop all the drugs and investigate for other causes of liver enzyme elevation, like we rule out viral infection, other bacterial infection. Okay. But the practical approach is to stop these 3 drugs, continue ethambutol alone, add another drug which will not alter the liver function problem. It can be a second line drug or first line drug. Okay, what are the other drugs which can be started? Which streptomycin does not have any problem with the liver, so we can start it. What is the dose of streptomycin? It is 15 milligram per kg body weight. So streptomycin can be started. What side effects it can produce? Ototoxic. So you have to examine the ENT part and make sure that there is no ear involved. Then we can start streptomycin. Then
How is streptomycin given?
IM.
IM. Okay. What else you can add?
Second line.
So you can add one more drug that may be from the second line drug. So you can start ofloxacin, levofloxacin, also whatever it is. Okay, that can be started. So it will be 3 drug regime. Okay, most of the TB conditions 3 drug regime is enough. Okay, but there is a problem that we'll discuss afterwards. So you stop all these 3 drugs, add another 3 drugs, and wait for how many days you'll wait? We have to restart other drugs one by one. How do you restart? Wait the SGOT, SGPT come back to the normal level, then start least hepato damaging drug in 25% of its dose. But which is the least hepato INH, then rifampicin, then only pyrazinamide. So INH can be started in 25% of the actual dose. 300 means somewhere around 75 or 100 you can start. Wait for 3 days. There is no SGOT, SGPT elevation. Increase to 50%. Wait for 3 days. No problem. 100%. Next, another drug, rifampicin. Okay. If rifampicin is there, then you have advantage. What is the action of rifampicin? How do this drug act? Where all it will act?
The bactericidal drugs.
What are the different TB organisms you know?
Sir, Mycobacterium tuberculosis.
I am not really talking about the name of the bacteria in terms of growth.
MDR and XDR. Sir.
There are 2 important growers, slow growers and rapid growers. Okay. So we are giving all the drugs, they act for rapid growers. Okay. They grow rapidly and come down rapidly. So most of the drug can act there. But slow growers are there. They grow slowly. Only rifampicin will act against that. Okay. So if you are not giving rifampicin, what happens to the patient? Suppose I am not giving rifampicin because of liver problem. What happens?
Resistance.
It will not produce resistance. Slow growers will slowly grow. So normally we finish the treatment by 6 months. Okay. This slow grower slowly increases after 6 months and the patient develops reaccumulation of the bacteria wherever it is and it produces symptoms. So if you are not giving rifampicin due to any reason, how long you have to continue ATT? That is the point. Okay, so due to some reason we are not able to give pyrazinamide or rifampicin or INH. So that drugs will not have any much effect there. But if you are not giving rifampicin, then you will have to continue the treatment for
6 more months.
18 months. Okay. So nearly 1.5 years we have to treat the patient if you are not able to give rifampicin. That is the problem of this drug. Rifampicin is only one drug which acts against slow growers, rapid growers, intracellular, extracellular. So rifampicin act all types of bacteria. So if you are not giving rifampicin, then it is for 18 months. If you are giving rifampicin, it is only how many months? 6 months. What is DOTS?
It's a direct observational.
Okay. So what is the change in DOTS and our routine treatment? We give 4 drug regime every day. Okay, DOTS? DOTS rifampicin will be given at least 3 days in a week. That's all. Okay. So that will be direct. It has to be directly given by the physician or a physician assistant, whoever it is. Okay. but it is different from a routine treatment. Routine treatment, rifampicin is given every day. Here, rifampicin is given alternate days or 3 days in a week, like that. Okay, that is DOT regime. Okay, if the patient is having TB of brain, which all drugs act there? So each area is different. Okay, you are discussing about abdomen. Almost all drugs will act. Okay, we don't have any problem in switching the drugs. But if the patient is having TB in the brain, like meningitis, whatever it is,
Rifampicin,
Okay.
which all drugs? We'll give all drugs. Which all drugs act better in an inflamed meninges?
streptomycin can act. Then
Pyrazinamide, streptomycin, INH. These are the 3 drugs that have got better penetration to inflamed meninges. Okay, rifampicin does not have good penetration. Even then, when there is TB, we have to give. In spine TB, what is the difference in treatment? Is there any difference in treatment? Duration is 9 months. Okay. According to many guidelines, it is 9 months. But WHO says in all type of TB, 6 months. Okay. But if rifampicin is not there, it is 18 months. Okay. When will you follow up this patient?
So this patient actually, because he's clinically improving, we'll be monitoring him, and he's advised to go to guest house and come 2 weeks later, sir.
Okay, what all investigation you do that time?
We can repeat a CBC, LFT.
Okay, LFT is very important. What else?
CBC,
uric
LFT,
acid.
Uric acid.
Which drug can increase the uric acid? Pyrazinamide.
Okay.
That can increase the uric acid, but normally even the uric acid is 12, 14. They will not have any clinical feature. So normally we don't treat this patient. We'll just watch for any symptoms. Okay, this will subside with its own by its own. Okay, if the patient is having altered liver enzymes in a TB patient, how do you know that this is granulomatous hepatitis? It's a part of TB. There we can give full dose of ATT. Or a patient is having a liver disease. Alkaline phosphatase is one investigation which will tell you that there is an obstructive jaundice. TB is a type of obstructive jaundice. Sarcoidosis is a type of obstructive jaundice. They're all alkaline phosphatase will be elevated. If alkaline phosphatase is elevated and SGOT, SGPT is elevated, then it's a part of TB. Okay, if that is not there, it's not a part of TB. So that should be very careful. What are the emergencies you see in TB? Port spine, rupture of the spine, and patient can have paraplegia. Then
The meningitis, TB
meningitis, meningoencephalitis, shunt, block in the CSF. Okay, then
acute hepatitis, TB.
acute hepatitis it is not a very common presentation. Choroiditis, that's an emergency. Then adrenalitis. For us, it is most important is an adrenalitis. How do they present? Suppose this hypotension. Okay, adrenalitis present with hypotension. So we'll have to give steroids. What are the indications of steroids in TB?
Adrenalitis.
One is adrenalitis. Okay.
Meningitis.
Pericarditis. Wherever pleura, peritoneum, pericardium involved, we have to give. Only in this patient we didn't give. Why we didn't give? Peritonitis, initial phases you can give, but if the peritonitis become very severe, when we give, there is a chance of perforation. That's why we avoided steroids in this case. Otherwise, early phase of all type of effusion we can give. But pleural effusion, if there is a massive effusion or reaccumulating effusion, then we can give. Otherwise, it is not recommended. Other conditions, other than all these things you told, where else we can give steroids? Peritonitis, pericarditis, massive pleural effusion, then adrenalitis, then meningitis, then eye involvement. So vision may lose. So we have to start choroid. Okay, choroid lesions. Then one more condition, we have to start steroid. genital TB, okay, especially in female patients, because chronically that can produce tube obstruction and patient can develop infertility. So we have to be very careful. Okay. So what happened?
Yeah. One more thing. So this is an extrapulmonary abdominal TB, right? What are the different subclassifications of abdominal TB?
Intestinal, peritoneal,
Okay.
um,
And visceral organs can be involved. And also there could be isolated lymphadenopathy.
yes, sir.
Also. So these are broad classifications. In the GI tract, what is the most common site which is involved?
Hepatic,
GI tract.
GI tract.
Ileocecal.
Ileocecal junction is the most common area.
Okay, and usually you have started the patient, and when, according to WHO guidelines, when do you say there is treatment failure in TB? At what point of time?
When there is after intensive phase, if the patient is still positive for.
It's usually 5 months of treatment. If he is remaining positive at the end of 5 months of treatment, then it can be classified as a treatment failure.
So you let again tap and see whether the patient is still. You can do ultrasound. You can clinical examination like improvement in clinical symptoms are good. This one. If you want to prove that this is persisting, then we need to take biopsy or something after 5 months. Otherwise, we will not be able to prove that this patient is completely improving, or some remaining things will be there or not.
If it is peritoneal TB, what is the expected long-term complication?
Adhesions and intestinal obstruction.
Chronic intestinal. Okay.
Okay.
Thank you.
Thank you.